Welcome to Oncology Today, optimizing the selection of first-line and maintenance therapy for patients with extensive-stage small cell lung cancer. This is medical oncologist Dr. Neil Love, and I'm joined today by Professor Martin Reck from the Lungen Clinic, Großhansdorf, in Großhansdorf, Germany. To begin, Professor Reck presents a case of a 76-year-old woman with extensive-stage small cell who's treated with first-line chemoimmunotherapy and maintenance lurbinectedin atezolizumab.
I think this is a really interesting case because this is a lady originally coming from the IMforte trial. So this was a 76-year-old female patient, also a smoker with a couple of relevant comorbidities. She had an arrhythmia, COPD, hypertension, history of psychiatric disease, and she was diagnosed in September 2022 with a metastatic small cell lung cancer coming from the left upper bronchus, and she had metastasis in the liver. So from September to December 2022, she was receiving 4 cycles of chemoimmunotherapy with atezolizumab. We had some issues with immune-mediated adverse events, hepatitis, thyroiditis. She was treated with steroids, carbimazole, but in the end, we could manage these side effects, and we had seen a quite good response. So in January 2023, the patient had recovered with the liver and the thyroid function. So we started the maintenance treatment with lurbinectedin and atezolizumab plus growth factors, the G-CSF. She had 1 episode of arrhythmia. But then we had, in May 2023, the first restaging. She had an improved partial response, really benefiting from this combination. So this patient was treated from May 2023 until January 26 with the combination of lurbinectedin and atezolizumab. She had received 42 cycles of this treatment with a dose reduction starting in November 24. And we have to say, since June 24, we haven't seen any clear evidence of an active tumor. So we are asking ourselves, does this lady have a complete remission after this intensive first-line and maintenance treatment? Tolerability was okay. She had some skin issues with the pruritus, and over the years, she had an increase in fatigue. So we decided in March this year, based on the ongoing response, to discontinue the treatment of lurbinectedin. We are just continuing with the IO monotherapy. Meanwhile, she had recovered from the fatigue, and we have to say from March 2026, with an ongoing, potentially complete response of a metastatic small cell lung cancer, that we have treated the patients over 3.5 years with a metastatic small cell lung cancer and a fabulous response. And this is really something which is of value for our patient.
Okay. All right. So let's, I want to kind of follow up a little bit on the things that you talked about and explore a little bit more about your cases as well. But just to begin, I want to reflect back on the fact that recently we actually did a program on small cell cancer with Dr. Jacob Sanj and Christine Hahn. And just, I thought it might be interesting. In the beginning, I wanted to get their take. You were talking a little bit about this in your talk on the biology of small cell and why it's so aggressive. So just to sort of make it kind of more interesting, you know, we have our weird way we do things. I asked ChatGPT to create a metaphor for small cell lung cancer, and they came up with a wildfire sparked in dry grass, which I thought was interesting. But they brought up what you were referring to in terms of P53 and RB1 and all, but anything more that you understand at a more biologic level about why it is that it grows so rapidly?
Well, I think the problem of small cell lung cancer, it's a complete heterogeneous cancer. So we do not have it's completely it's completely different from, let's say, genetic-driven cancers like EGF receptor mutated or ALK translocated non-small cell lung cancer, where we do see some genetic homogeneity, and this is not the case in small cell lung cancer. It's like a genetic chaos. We have several tumor lines, and a lot of these tumor lines are extremely resistant against any treatment, and there are multiple, let's say, ways to interrogate with the effects on the small cell lung cancer. So it's also a very dynamic tumor that we do see there, and that's the reason why we have the resistance so early after the systemic chemotherapy. We try to do this from different angles. I remember when I was trained, we had cross-resistant, non-cross-resistant chemotherapeutic schedules that we applied to the patient. We didn't see any improvement in overall survival. We prolonged the chemotherapy, just the first chemotherapy. We haven't seen any benefit. So it's just a challenging heterogeneous disease.
Yeah, that's a good thought. So another thing was, I hope you don't mind, but I showed them on this webinar your slide of the mechanisms of lurbinectedin just to see what they thought about it, and then you just presented it. But I wonder if you could just elaborate more on the, quote, immunogenic effect of lurbinectedin. I mean, do you see this with other chemotherapeutic agents, or is there something different about LURB?
Well, it's I think this is something which is coming from the lab of Louis Passares. He's done a lot of work, and he had preclinical experiments looking on the level of T-cell activation, looking on the level of the microenvironment modulation, surrogate markers, and he could see a clear correlation with lurbinectedin that he hasn't seen with other conventional cytotoxic agents like platinum agents or whatever. And the other point was that he has seen a clear synergistic activity in the combination with the checkpoint inhibitor. And I think this was the background for the next step of development. So we know lurbinectedin already as a treatment opportunity for pre-treated patients with small cell lung cancer. There we use it just as a simple cytotoxic drug. But I think it does have more potential, and this is the reason why we are combining this with the checkpoint inhibitor. And he could show this in the preclinical setting. He could show this in a very small exploratory phase 2 trial. And I think we have seen also somewhat the confirmation there in the IMforte trial as well.
So I don't know if I'm the only one who has trouble understanding biologic pathways and all, but I'm always looking for a better way to understand things. While we're bringing this up in terms of immune effects, and I know that's a great interest of yours, I was curious, of course, we were talking on this webinar about maybe the future in tarlatamab maintenance. And I was wondering, if you combine a bispecific and PD-1 agent, and I was asking them also, and I'm curious what your thoughts are they like just completely unrelated parts of the immune system, or is there any potential synergy between like a bispecific and a PD-1 agent?
Well, I'm not so sure whether there is a big synergy between these two types of agents. So the tarlatamab is more bringing the immune cells to the microenvironment of small cell lung cancer. The PD-1 is doing another job. They are substituting each other. Whether they are really synergistic, I think this is something where we are still lacking biological data. And this is one of the big discussions that we do have as the T-cell engagers are coming more and more into the frontline treatment of small cell lung cancer. Do we really need the checkpoint inhibitor besides the tarlatamab and the T-cell engager? Yeah. And this will be a very important question for the future, because now we have the phase 3 first-line trials investigating chemotherapy, checkpoint inhibitor, and T-cell engager. But the big question is, do we really need the checkpoint inhibitor when we have a T-cell engager in place? There is a lot of more biological work to be done. I'm not so sure whether we really do need the checkpoint inhibitor there.
Yeah, it's interesting. Obviously, we talk all the time about CD3 bispecifics in myeloma and lymphoma, but they don't use PD-1 agents in myeloma and lymphoma, so there are no combinations there to reference it. Anyhow, kind of getting back to small cell in general, another thing about small cell, personally, I don't know when it occurred for you, but my whole view of small cell changed last fall, I think it was around October. We were working on a CME program with another one of your colleagues, Corey Langer, and he put up a slide very similar to what you'd put up in your talk showing long-term survival in the IO chemo small cell trial, talking about a tail on the curve. And that was the first time that I kind of came into my consciousness. We actually did a webinar a few weeks later with Dr. Pazaris, incidentally, and I asked him about it as well, and he was like, yeah, 12, the numbers everybody's quoting now, 12% of 5 years maybe. Now, you present this incredible case in your talk of this woman who's been treated for 3.5 years with extensive stage disease. And incidentally, one thing I want to ask you about her is, first of all, any thoughts about potentially using cell-free DNA to determine whether to stop therapy in a patient like her?
Yeah. I think this is the new topic. It's the case when we talk about the long periods of maintenance treatment, when we have a radiologically stable situation. Do these patients really need this aggressive combination? Because there are adverse events, in particular when you are combining with lurbinectedin, the patients are getting fatigue, they are getting hematological toxicity. So it would be very helpful to have a surrogate marker to de-escalate the treatment somewhere. I think in small cell lung cancer we are starting. Currently, we do not have that good data. We have the first data for non-small cell lung cancer, in particular for oncogenic-driven non-small cell lung cancer. Where we do see the correlation of ctDNA clearance and the targeted therapies and the risk of relapse of the disease. I think there has been more work to be done. Actually, I think it's a very interesting approach. The problem of small cell lung cancer, I'm not so sure whether we will see a really good cell-free clearance, ctDNA clearance in these patients, because these are so aggressive, persistent tumors that probably most of the patients will never have a complete clearance after the systemic treatment.
Well, actually, now that I think about it, you were talking about the biology of it. These are tumor-informed assays where they look, they do NGS on these tumors. What do you see when you do NGS on small cell?
Well, when we perform NGS, we do see multiple mutations, and in the past we also tried to work on some targeted therapies. We had some specific agents that we investigated in clinical trials. I have to say that so far the outcomes have been a little bit disappointing. Could never be confirmed in randomized trials. There is this story about the PARP inhibitors with the schlafen gene, that potentially there might be a correlation to an enhanced efficacy. I think the data so far are coming for very limited phase 2 trials. We need a confirmation in a larger data set. But unfortunately, this approach of a targeted therapy in small cell lung cancer so far has not been very successful.
The other thing about your patient who's out 3.5 years is you mentioned she has some autoimmune issues, thyroid, which of course is very common, but also hepatitis. And I don't know how much of an issue it was. A lot of time that can be a problem. And I don't know, for some reason I haven't thought or heard too much about autoimmune toxicity with small cell, maybe because they're on it for such a short period of time. But how often do you see serious autoimmune toxicity, first-line extensive stage disease? And do you think there's any correlation between autoimmune toxicity and benefit, the fact that she did so well?
Yeah. So when we talk about severe immune-related adverse events, I do see this in, let's say, perhaps 10 to 14% of my patients. Actually, I can not say that for me clinically, that there's a very strong correlation of the IO toxicity or the grade of IO toxicity and efficacy. There are some, I would say, some anecdotal patients who only could tolerate one cycle of immunotherapy and then had a dramatic immune toxicity. There, indeed, I have 2 or 3 patients with a very long-lasting response. So they must have a very unique immunogenic activation in their host system. But this normally, we do not see this clear correlation between the immune toxicity or the grade of immune toxicity and the efficacy in small cell lung cancer. I think it's related also to the aggressivity of this tumor.
So to me, that moment when I saw, this concept of a tail on the curve, even though it's, pretty modest, whether it's 12% or, whatever it might be, not to mention, and I bring this up all the time in other tumors, because to me, it's one of the most interesting things I've heard in oncology. I mean, the median survival is still, around a year. And yet you have this small group of people. Now, this lady you have is like NED. So, maybe even cured. Are most of the people, do we know, when they get out to 5 years, are they free of disease, or they still have noticeable disease?
Yeah, so I have some of these patients in my clinics. For example, I have a patient who had a brain metastatic small cell lung cancer, and I was very skeptic about the efficacy of our systemic therapy, and she got a complete response, and we stopped treatment 2 years ago, and the disease happened 5 years ago. So we do see this in our clinics. It's a rare event. I think it's very difficult to talk about cure of the disease. This is the same problem that we do have in metastatic non-small cell lung cancer when we treat them with a checkpoint inhibitor. So we have this 24% surviving the 8 years after the monotherapy. But the question is, if you do see a progression after 6 years, do you really have a new cancer disease, or do you have a relapse of the original disease? We did some work in Germany where we undertook a lot of biopsies in patients progressing after 2 years after checkpoint blockade. And interestingly, in the majority of cases, either we found new lung cancer, secondary lung cancer, or inflammatory events. So I think if we really have a stabilization of 2 or 3 years, perhaps we can talk about the cure of the disease, but we have to be very aware, because there is the high risk of getting another cancer.
Yeah, that's a great point. And I mean, I don't know whether you call CML curable, but if you die of something else and never have any symptoms, that's kind of a functional cure. And if you're out there 5 years doing well, I think that says something. So the reason I felt this was so important, I mean, it's not like it's 50% of, people getting cured, at least at this point, maybe with tarlatamab. But I wonder whether this really should potentially fundamentally change the way people look at this extensive stage disease and talk about it with patients. Because to me, if you have I mean, I know a lot of these people have comorbidities, they're older, et cetera. But even so, but particularly if you have a patient who maybe isn't so old or doesn't have that many comorbidities, the difference between saying, listen, this is going to be a very, very difficult situation. There's no way you're going to get beyond, a couple years. And this is a very difficult situation and not much of a chance, but maybe there is a 10 or 15, it's like changes the therapy, the idea behind your therapy. Maybe you're willing to go through more toxicity if you know that there's a possibility that's not like 1% of cure. And I'm wondering whether you feel like it's changed the way you talk with patients when you begin treatment.
Absolutely. So I think when I started 30 years ago, this was in the first times of platinum etoposide, and we said, well, on the one hand, it's good to have a small cell lung cancer. We will see a very fast response. But for all patients with metastatic small cell lung cancer, we have to say you have to be prepared that we only can control the tumor for perhaps 10 months or a year, but not longer. And this has now completely changed with the new opportunities. And of course, this integration of the checkpoint inhibitor is the first step. I think the maintenance approach with lurbinectedin is the next step. There will be some long-term survivors. And actually, I think the major breakthrough will be with the implementation of the T-cell engager. So if we do see a patient responding to a T-cell engager, he will survive for months or even years. So I have talked to colleagues who have patients on tarlatamab or other T-cell engagers for many, many years, and these have been refractory diseases. So I think the angle of the perspective in small cell lung cancer really has completely changed.
Yeah, and I thought, from my point of view, the timing was perfect because I kind of picked this up at the same time I was hearing about the Forte trial. And again, initial reaction was, oh, do you want to cause morbidity in a palliative situation? But on the other hand, maybe it's not exactly 100% palliative. You still have the possibility. I don't know how
Yeah.
much that is sort of chemo-like. You were pointing out the immune effects. It looked like, I know they presented more data at the ESMO meeting. The survival didn't look as great, but I don't think that was a planned analysis. I mean, when you think about using lurbinectedin, are you hoping that you're going to maybe bump up the tail a little bit?
This is clearly so. I think I have to tell you, I had a couple of patients in the IMforte trial, and I'm doing this now regularly. And the problem is when you just have the checkpoint inhibitor in the consolidation, so you have the good response, but you have to see that 8 of 10 or 9 of 10 will progress during the first 3 to 4 cycles of the checkpoint inhibitor. And this has been different with the lurbinectedin combination. So we had more patients being stable, radiological and clinical as well. There is this increased toxicity, but I have to tell you, with the GCSF support and with the dose modification of lurbinectedin, this toxicity was manageable in the majority of this patient, and this is still the case. So you can play with the dose, you can adjust the dose. There are multiple ways to adjust the treatment, but I think this is a really valuable new approach to enhance the efficacy of your first-line treatment.
And of course, allowing the patient to be part of that decision. Anytime a difficult decision in oncology, if the patient wants to be involved, that helps a lot.
Yeah.
I'll tell you an interesting story related to this. We were actually at the Society of Gynecologic Oncology meetings in Puerto Rico last weekend. We did 4 programs. One of the programs was on ovarian cancer, and we were talking about a new trial. Ovarian has not had IOs in it at all. They just can't find anything that works. And finally, at ESMO, there was a positive trial, chemo plus pembrolizumab, and the principal investigator was in the program on last Sunday, Nicoletta Colombo. I don't know if she's an Italian investigator. And, I was reflecting back to her what had happened with the small cell IO studies. When they first came out, the benefit looked kind of modest. I think people said, well, okay, it is, you compare it against the risk, it's worth doing, but it didn't look very exciting, to be honest with you. But then with longer follow-up, now I'm getting excited when I see the tail on the curve. And
Yeah.
same thing with her study. I was pointing that out to her because it was the same thing. There was, it got approved. So, but it was a modest advance, I think 0.75 or something hazard rate for PFS and survival. But she wasn't aware of what happened. And she went and looked it up and she said, you're right. And she looked and she said, there is a tail there. So it's a principle, I think, that maybe we need to look at a little bit more because it makes a big difference if you have the reasonable possibility, I think. I don't know.
Yeah, yeah. And I think this is a secret of the checkpoint inhibitors, that perhaps this has been also the story of non-small cell lung cancer. So perhaps you should not only look on the progression-free survival or the response rate. So the value of adding the checkpoint inhibitor really comes with the long-term survival. And there we do see the difference. Sometimes we have difficulties in seeing a tremendous difference in the median survival, but when you then look onto the follow-up, you do see another quality of long-term survival, another layer of long-term survival. And this is really a new kind of assessment. So we thought about how to cover this from a statistical point of view. It's not so easy because it's not every time reflected in the conventional hazard ratio, but it's there. And I think it does mean something for patients because if you do have 5% or 15% living after 5 years, this is an essential difference.
Yeah, I think it'd be interesting to do a study of, we've done this before, of patients and see how much value they put on it. So I want to do a quick Dr. Reck Journal Club, a couple of papers I want to ask you about. One from the World Lung Cancer paper on Lurbi, Atezo as first-line maintenance. I guess this is a follow-up safety, looking at more safety in the IMforte study. Anything there? And when you look more, you were referring in general to the issues that come up in the maintenance situation. Anything that you presented there that you want to comment on, particularly in terms of longer term issues that you see as you follow patients longer?
Well, I think we did this analysis and we wanted to understand when does these adverse events happen, when they have the maintenance treatment. And do we have an issue with the long-lasting tolerability of these agents? And the major outcome was the majority of these adverse events or severe adverse events do happen during the first 3 months of treatment. So if you are successful to adjust the dose for the majority of patients later on, this combination becomes feasible. And I think this was the major outcome of this updated safety analysis.
And, I think we see that a lot in oncology. So let me ask you, this lady on has been on lurbinectedin and atezo for 3.5 years?
Yeah. But we adjusted also the dose at November 24 due to fatigue and some other side effects. Yeah.
But she's still on it. That's amazing. So another paper I want to ask you about was from ESMO. Patients with extensive small cell and poor performance status getting atezocarboetopicides, SPACE study. That sounds very interesting and relevant. What did you present there?
Yeah, so this was some kind of real-world study we have done in Germany with a couple of trial sites. And the focus was really to look on the patients with the PS2. And we were a little bit surprised by the outcomes because actually the survival was not very compelling. That represented overall the clinical efficacy was not very compelling. And what we learned from this study was that this is really a special population, the small cell population with a reduced performance status, and it's really hard to show benefit in that group of patients. So this is something where we really need perhaps a little bit more guidance. We need to include them into our prospective trials to learn about more what drives the performance status in this group of patients and what intensity of treatment can we offer to these patients and where do we face the frontiers of tolerability. So I think this has been more a learning trial that really the PS2 patients with small cell lung cancer are not doing very promising.
When you think about it, if you could make up a regimen you'd like to study in those patients, what would you like to study as first-line treatment? I'm guessing it might include tarlatamab.
Yeah, so we are doing such an academic trial in Germany. It's something we call the SPACE 2 trial.
Really?
So it's not the 4-drug combination, but it's a very reduced combination, including the tarlatamab. And I think this is an interesting question because we discussed this a lot. Who are the patients not eligible for treatment with tarlatamab? Is this really driven by the performance status? And when you're treating patients with tarlatamab, the critical part is the period of the first 2 to 3 injections. So if you do see the CRS or the ICANS, you do see this during the early treatment. And after that, tarlatamab becomes a really easy drug, I would say. It can be easily given in an outpatient clinics and so on, and it easily can be tolerated also by patients with a reduced performance status. So the big question is how to guide patients with a reduced performance status through this first treatment intervals, the first treatment assessments.
Another question I wanted to ask you, when you look at people presenting with small cell who are PS2, how much of that is the tumor and how much of it is comorbidities? Like overall?
This is an excellent question. So as I mentioned in my talk, the majority of these patients are presenting in a really reduced status, but this is mostly driven by the tumor. And this is exactly the reason why in a couple of these trials, there is some kind of rescue chemotherapy permitted. So the patients just can receive 1 cycle of rescue chemotherapy to reduce the tumor burden, to improve the performance status, and then to go on with the study treatment. And I would say in small cell lung cancer, um, at least 50% of the patients are presenting in a reduced performance status related to the tumor disease, not necessarily to the comorbidities. The difficulty is the other half of the patients who have a reduced performance status related to the comorbidities. There you really can go into trouble with a very intensive treatment.
So moving forward, I'm curious where you see the future with small cell. You have immune therapy. I don't know whether we have vaccines or CAR T or new small molecules. Anything on the immediate horizon you're excited about?
So I think there are so many compounds coming into small cell lung cancer, and it has become really exciting. I think the major breakthrough will be the T-cell engagers, and we are not talking only about tarlatamab. There are more to come. There is the brixtamig, there is the ex-harpoon compound, but there are more to come. And besides that, what we also have seen quite surprisingly, there are a number of very interesting ADCs who have shown tremendous efficacy in pretreated small cell lung cancer. A lot of them are now in phase 3 second-line trials against standard of care. So we have the CES6 ADCs, we have the B7H3 ADCs, we have other ones. So this is a very exciting field now evolving. And we also have the bispecifics coming into the landscape of small cell lung cancer, the anti-PD-1, anti-VEGF agents. So there's the ivonescimab, which is the Summit drug. There is the pumitamig, which is the BioNTech drug. Pfizer also has acquired one of these agents. They also are now going into small cell lung cancer. They have quite good preliminary early data on this disease. So this would be the big areas where I do see major progress in the management of small cell lung cancer.
Yeah, we were talking about these bispecifics, PD-1, VEGF, like ivonescimab, and the other pumitamig that you mentioned. I was surprised that would work in small cell, like VEGF and small cell. Is VEGF an issue with small cell?
So we do not know. We have a very limited experience with bevacizumab. We have done a phase 2 trial with bevacizumab, but it was not randomized. So we do not really know. We never tested the VEGF TKAs in small cell lung cancer. Looking on the early data, for example, for pumitamig in small cell lung cancer, at least this response rate and the duration of response looked quite promising. So we will see. The question is, will be the long-lasting effect, and this is something that we do not really know from the anti-VEGF agents, whether they really have a striking, long-lasting effect on the overall survival rate. So this is something we have to explore in our trials. But actually, also small cell lung cancer is a weather-driven disease, and therefore I could imagine that anti-VEGF agents does have an activity. The reason not to use them in small cell lung cancer in past times more has been related to the potential risk of toxicities. And this is something which is quite unique of this new bispecific antibodies, that the tolerability profile, particularly the tolerability profile for the anti-angiogenic characteristic adverse events, looks quite good and interesting.
So yeah, I just got a flash memory of something causing hemoptysis. I think it was lung cancer. Was it Bev?
It was Bev and squamous cell cancer. So there were the 6 patients with bevacizumab and squamous cell lung cancer. And that was the reason why the development of Bev and squamous cell was discontinued.
That was a long time ago. So you mentioned ADCs, and of course, we're talking about that all the time in oncology. You know, when you look at small cell, it looks like you are getting a nice solid new bump here with the bispecific tarlatamab. Looking at these ADCs, you know, you mentioned B7H3, there's IDXD. I mean, it looks like it has pretty substantial, response rate. Are you optimistic that it's going to be another sort of boost along towards maybe even the tail of the curve eventually?
So currently I do see these agents more in the pre-treated fields. And to be honest, the only second-line treatment that has been available before tarlatamab has been topotecan or irinotecan, and perhaps lurbinectedin in selected patients, and no one was really excited about the topotecan. And currently, all the trials are exploring these ADCs in the pre-treated patients. And I think this is extremely important because when we look on our patients, even with the new opportunities in first-line treatment, we are still talking about small cell lung cancer. And eventually, these patients will progress. It will be in need of an efficacious second-line treatment. And this could be a fantastic giant chance for these new ADCs and the new agents there. Whether they will come into the frontline setting, I do not really know, because there's happening so much with the T-cell engagers and the other agents in the first-line setting that it might be a bit crowded now to place a new ADC in this scenario.
So I never imagined 5 years ago that we'd be talking about small cell for like an hour and still have more stuff to talk about. But I'm just going to ask you a couple other small cell questions in general, taking a step back, sort of, let's say, small cell 101. So one thing I noticed that you seem to be very involved, at least you have a lot of papers involved with lung cancer screening. And yeah. I was wondering about the impact of screening in terms of small cell, because I think normally you think about small cell, I don't know, it's just the model of it, you wouldn't think about it. But do you see a stage migration or stage shift when when the people get screened, when they get picked up with small cell? Are they more likely to have limited stage disease? And is screening useful in small cell?
So actually, the lung cancer screening, it's a risk-adopted screening. So we are looking on patients with a smoking history, and therefore it's quite natural that we also will detect early stage small cell lung cancer. So it's not so much reflected in the screening trials, but it is there. So we have done also a trial in northern Germany where we screened 5,000 risk candidates. We have got 100, a little bit more, 100 lung cancers there. Some of them also were small cell lung cancers, early stage small cell lung cancer. So I think the screening might give us the opportunity to diagnose more patients with early stage small cell lung cancer. I think these are data to be generated, but there is a chance that the stage migration also will be valid for small cell lung cancer.
I mean, again, talking about the tail on the curve, to me, the limited stage disease, the Adriatic study, the survival benefit is really impressive. So, I mean, I don't know what the tail on the curve is there in that situation, but it looks a lot more favorable than kind of what I expected.
Yeah, and I think this has been the first positive consolidation trial in small cell lung cancer, and let's say the proof of the efficacy of an immunotherapy in limited disease small cell lung cancer. And there are a couple of trials now building up on the Adriatic trial. So there are also trials trying to investigate the T-cell engagers in combination with the checkpoint inhibitors in this consolidation settings, reaching another level of efficacy after chemoradiotherapy. So actually, this is the natural field to explore more therapeutic opportunities, because these are patients who are perceived as curative patients with small cell lung cancer because they are non-metastatic.
I mean, overall survival benefit was 22 months. I mean, you don't see that too often in oncology. One final question, again, just sort of a basic question about small cell in terms of paraneoplastic syndromes, and particularly Eaton-Lambert syndrome. Can you kind of refresh us on how you diagnose that, the challenge in making the clinical diagnosis, and whether it even matters to make the diagnosis therapeutically?
So the problem is it's a rare event, this Lambert-Eaton syndrome. And the problem is it's an extremely poor prognostic factor. So like a couple of other paraneoplastic syndrome, it does not really respond to the systemic therapy. So all the patients with the Lambert-Eaton syndrome that I've seen with small cell lung cancer, unfortunately, had a really short prognosis and did not benefit really from the systemic treatment. There are specific antibodies you can investigate for the Lambert-Eaton syndrome, but primarily it's a clinical diagnosis.
What is it about it that differentiates it from, I don't know, like just proximal myopathy that people get with cachexia and other weaknesses?
Yeah, normally it's the exclusion of other comorbidities, and I think when you have a small cell lung cancer confirmed, and it's a really small cell lung cancer, the diagnosis is quite clear.
This concludes our program. Special thanks to Professor Reck, and thank you for joining. Conflict of interest statements for the faculty can be found in the program notes. Throughout this program, the use of agents and treatments that are not approved may have been discussed. Check out the package inserts for more. This is Dr. Neil Love for Oncology Today.